Good morning, ladies and gentlemen. For today's CPC, it's my pleasure to see Professor Y.K. Chawla, who is former Director and Head Department of Hepatology, joining us for today's CPC, and for today's staff CPC, the clinical discussion would be Professor Madhumita, who is a young, energetic assistant professor in the department. Associate? I'm sorry.
Okay, I think this is already on. Good morning, everyone. So I'm here to present a very interesting multidisciplinary case. And I think most cases nowadays are multidisciplinary, so that's a moot point. So this is the case of a 21-year-old lady who presented with twin pregnancy at 34 plus 6 weeks POG. And she had history of being jaundiced for 10 days with a background history of pruritus since the last 2.5 months. That means since the third trimester. And she had increased blood pressure records as noted by her primary clinician in Hoshiarpur. And she was referred with these complaints to the PGI emergency. This was a spontaneous conception. The patient was fully booked, immunized, was in regular contact with her primary OBGYN. And she had pruritus at about 24 weeks of gestation. This is 2016. Nobody did the bile acid levels. She was given UDCA, pruritus was relieved. Thereafter, she was found on her ANC visits to have high blood pressure records. She was given some antihypertensive. It's not clear in the file, but apparently it was labetalol as per some notes. After being noticed to have hypertension, she started complaining of jaundice and pedal edema about the same time. And then for these complaints, she was referred as a complicated case to PGI. She had one prior history of spontaneous abortion at 6 weeks. Other than that, there was no complaint of fever, nausea, vomiting, altered mentation, bleeding, any abdominal pain. Since this was jaundice with pruritus, there was no history of play stools, seizures, blurring of vision. She was perceiving normal fetal movements at the time of referral. The past history was not significant, which was not suggestive of any other autoimmune disease or thyroid disease, diabetes, hypertension, asthma. And the family history is not really mentioned in the file. I assume it was not contributory. On examination in the emergency, her blood pressure was mildly elevated, but a high blood pressure record was documented in the CLR, for which she received labetalol injectable. And respiratory rate was okay. She was not pale, at least in the examination notes. And she was deeply ectric. There was pedal edema. And otherwise, the chest and cardiovascular system is reported to be normal at presentation. The emergency notes note that there was no altered mentation, but the SR in the clean labor room clearly documents that she was drowsy, but she was conscious and oriented. After her delivery in the CLR, she was intubated in the LICU, so that is the way the CNS function was. On abdominal examination, there was no hepatosplenomegaly and no ascites at presentation. And the uterus was appropriate for gestational age, and both the fetal heart sounds were heard. Now let's look carefully at what data we had right at the presentation. So when she came, she was anemic, even though pallor was not obvious. Her counts were elevated at presentation. So this is reports from outside. Please note she came to us on 17th night and was delivered the same day. Platelets were normal, and you will note that they were normal till the time of her delivery, although they are starting to drop at this point. Creatinine was elevated right at baseline. So she came with high counts and AKI. Her bilirubin was 14, and you will note here that it is a conjugated hyperbilirubinemia. Whereas as the course goes on, her bilirubin continues to rise, and you will notice a gap between the direct and indirect bilirubin, which suggests something else is happening. So other than a pure biliary, both pure hepatic component, hemolysis is coming somewhere post-delivery. Enzymes, you will notice, are less than 400 international units. So definitely there is jaundice, hepatocellular pattern. Albumin and protein were reduced. So this lady with PIH, clearly, she has a low albumin, AKI, raised counts at presentation. Another interesting point which points to this hemolysis component is the elevation of LDH and the uric acid, which was also elevated. One more thing that is very important to note here, her cholesterol was low. So this is a patient who has hepatocellular dysfunction right at the outset. There is an INR elevation, which I'll come to, hepatocellular form of jaundice with some element of hemolysis that occurs later. Capillary ammonia has been documented to be high, uric acid high. RBS was low right from the labor room. She had recurrent bouts of hyperglycemia, and she was treated with parenteral dextrose for the same, even up to the LICU. And this was the day she was delivered. She had coagulation failure, anemia. She received about 8 vacs of PRBC and about 15 vacs of cryo and FFP. So a lot of blood components given here. And after her delivery, she was intubated in the LICU because her sensorium did not improve after delivery. So that's also an interesting point to note. The other investigations, let's come to the coagulogram. At the outset, only she had a deranged INR. Fibrinogen was low, but this was only documented later in the case file. And she has received blood transfusion, so this is a partial correction. Despite that, you will notice postpartum, when she had atonic PPH, this patient had worsening of her coagulation failure. D-dimer was persistently rising throughout her course, and fibrinogen went down. All this is partially corrected. So she's received frequent blood transfusions peri-delivery. We looked for hemolysis because this was suspected, and few schistocytes were noticed on the peripheral blood smear. Retic was 1.7. Unfortunately, we couldn't get the slides for this. Later on, after her delivery, she developed ascites, which was consistent with SBP. It was high SAG and low protein at the outset. Only one incongruous report is there of protein 4.8. But there are 3 other reports which are showing a high SAG, low protein ascites consistent with portal hypertension. And in ALF, as this patient was, we do have portal hypertension because of massive parenchymal collapse. We also had evidence of multiple sites of sepsis. She cultured enterococcus from the blood. Even her ascitic fluid and blood culture showed Burkholderia later on. This is pre-demise, and this report was received post-mortem. She had atonic PPH, and she was evacuated with a DNC later, so she had Klebsiella pneumoniae in the RPOC. So multiple sites of infection and sepsis documented in this patient. Another thing I'd like to highlight here on her ABG, she was having a compensated metabolic acidosis right from the presentation in the CLR, lactic acid acidosis which continues to rise. And initially she was hyperventilating because she's blowing out CO2 here, but later on it became a combination of both metabolic and respiratory. We had an echo which showed that there was no chronic pulmonary thromboembolism. Why? Because effusions and ascites developed later. The ultrasound of the abdomen at the outset showed a grade 1 fatty liver. So this is really important because we're looking in terms of ALF in a pregnant woman, and we need to look for hepatic steatosis because AFLP is one of the differential. Normal contour and size, which is suggestive that there was no chronic liver disease. Portal vein, hepatic vein is normal because we have to rule out portal vein thrombosis, hepatic vein outflow tract obstruction. Since there was history of jaundice with pruritus, no extrahepatic biliary obstruction, and kidneys were normal, no free fluid, twin live intrauterine fetuses at presentation. So this is a very important piece of information. Later on, of course, after her delivery, she developed ascites, pleural effusion. There were some RPOCs which were evacuated, which cultured Klebsiella later. And later on, again, because we were looking for persistent sepsis, this ascites showed some internal echoes, which suggested there was peritoneal infection for sure. Another point, since it's the case of PIH and we are looking at AKI right at the outset, we need to look at the active sediment, whether this is a glomerulopathy, whether this is a tubular disorder. So for pre-eclampsia, we need to actually quantify what was the total amount of protein. So there was one report with a good volume collection of around 1500 ml, which suggests there was subnephrotic proteinuria, but otherwise the sediment was blunt. There were no dysmorphic RBCs, or at least that's what's recorded in the case file. So coming back to this patient in general, this was a patient with a provisional diagnosis of acute liver failure, possibly pregnancy-related AFLP. She was icteric, anemic, had pedal edema. She had high blood pressure records, which were consistent with pre-eclampsia, now presenting with ALF. So what were the points which favored AFLP here? She had steatotic liver, recurrent hypoglycemia, very high bilirubin, which was predominantly conjugated at the outset. She had coagulation failure at the outset and a fatty liver on ultrasound, and all of her blood work for chronic and acute viral markers, dengue, malaria, etc., they were all negative. So this is how the Swansea criteria created for AFLP. So diagnosis of AFLP was correctly made by the treating unit, and she was started on NAC. The coagulation failure was corrected because at the time of delivery, she also had atonic PPH. She had spontaneous delivery. There was no induction, one fresh stillbirth and one early neonatal death. So this was unfortunate. Even though the mother went into the labor, both the children were lost, and ultimately we lost the mother as well. So this is a very fulminant case. So the atonic PPH was managed. The patient never went into shock. This has been documented in the records. But since she did not improve after delivery and her sensorium was worsening after the delivery, she was immediately intubated in the LICU. So it's a combination of both metabolic encephalopathy plus hepatic encephalopathy in the ICU. Puerperal sepsis, and I've documented there are multiple sites. Ascites, lung, because purulent ET tube secretions have been documented, and of course the retained POC. So 3 sites, and we've got 3 different organisms: Burkholderia, Klebsiella, Enterococcus, and Candida was also seen in 1 urine sample. She was given appropriate antibiotics. Antifungals were added by day 4, so this was absolutely appropriate. Colistin was given early. Initial cultures were sterile, but later on, of course, she had Enterococcus. She developed, despite the delivery, normally we would expect when we deliver such a child, if it was pure AFLP, the mother should improve because the load of lipids that come from the fetus and from the placenta, the metabolic intermediates which actually precipitate liver failure and LCHAR deficiency. Once it is out, the placenta is out, we would expect the mother to improve, but she didn't. So we need to see why. So what was atypical about this case? She developed LRTI, the secretions were purulent, and she developed refractory shock and ultimately passed away. We know she also had hemolytic anemia because we have looked at it. The type of hemolytic anemia we are going to discuss. What could it be? So the unit gave a diagnosis of AFLP with SBP. I agree, because there was secondary portal hypertension due to massive liver failure. She was delivered spontaneously with an atonic PPH, which was managed. Multi-organ dysfunction syndrome because of sepsis with DIC and AKI. And the cause of death reported was refractory septic shock and DIC. So what could we have done different, and how could this diagnosis have been modified further? Well, the main issue is just the single diagnosis of AFLP. Now, these are artificial labels that have been given by us, but let's see whether she meets the criteria for AFLP as per the Swansea criteria. Yes, she meets all of these which are highlighted: bilirubin, low sugars, high creatinine, elevated blood cell count, ammonia, uric acid, prothrombin time, low platelet, low fibrinogen. But please note the platelet count became low after her delivery when she had atonic PPH and when her hemolysis started happening. So there's something else going on here. So she meets all these criteria, but she also had elevated blood pressure records. So is this a different disease? Can they both exist together? Can pre-eclampsia coexist with AFLP? And that's the answer is yes. That's what we are here to communicate. So she definitely did meet criteria for pre-eclampsia, not so much HELP. And what happens, how do we decide which one predominates? Well, anyone with a very high bilirubin, like this one, 14 bilirubin at the outside, anyone with coagulation failure, anyone with AKI, anyone with hepatic encephalopathy, favors an ALF phenotype and therefore favors AFLP if she meets criteria and should be managed as such. Patients who have a lower bilirubin, elevated blood pressure records and proteinuria, this favors pre-eclampsia. So this patient obviously had a combination of both. What makes it more interesting is there was some pruritus at 24 weeks which responded to UDCA. We don't know her LFT at the time. This is 2016. No one was doing bile acid levels. So there's also a possibility that the patient had ICP, and yes, all 3 can coexist. So we did not have the bile acid levels. APLA workup has not been done, 2016. To distinguish whether this is hemolytic uremic syndrome or just septic AKI going to ATN, ideally we should have this, because pregnancy-related atypical HUS, we require these to differentiate between TTP and HUS. BP records we know are high, so pre-eclampsia definitely meets the criteria. Why I'm not saying HELP is because HELP would require just a low platelet, liver enzymes elevated, such a high bilirubin, hypoglycemia, INR being high. This is not seen with HELP syndrome. So this was atypical about this patient, and we'll just be discussing about the renal failure because she had subnephrotic proteinuria. And renal failure, of course, is very common with AFLP, but can happen with preeclampsia as well. Does she meet the criteria for preeclampsia? Yes, she had proteinuria, she had an elevated creatinine, she had pulmonary edema later on in the course. Of course, this could be something else. She had pedal edema, high blood pressure records, and definitely was documented to have a hypertensive emergency peri-delivery. What does not favor preeclampsia here is the coagulation failure and the very high bilirubin, which is pointing towards AFLP. So did this patient have preeclampsia first? And because of an associated metabolic deficiency, maybe LCHAR deficiency, developed AFLP later as the phenotype? Possibly. So does she meet the criteria for severe preeclampsia? Yes. But since we had a very high bilirubin, coagulation failure, and encephalopathy, we managed it as ALF, which was absolutely right by the treating unit. And another thing is that the thrombocytopenia was not there till the delivery, and the hemolytic anemia also occurred after the delivery. So this would be consistent with an atypical HUS thrombotic microangiopathy, which is pregnancy precipitated. So I would not label this patient as HELP. I would label her as preeclampsia complicated by AFLP. So let's just look at the criteria very quickly. So 2 points which need to be carefully looked at is the degree of proteinuria, recurrent hypoglycemia, and of course hypertension. So in AFLP generally checks all of these boxes. Preeclampsia, some of the boxes are checked. But very important is TTP is unlikely because they don't have predominant jaundice and liver failure or recurrent hypoglycemia. HUS, yes, atypical HUS, she meets the criteria, pregnancy precipitated. So this would be ADAMTS13 and this would be complement mediated pathogenesis. So this patient probably had a criteria for both. But she should have been managed as AFLP, which was correct as a treating unit. Why did she have this AKI? Right at the outset, the patient had AKI. So my differential would be both preeclampsia and AFLP. Both can have AKI right at the outset. After the delivery, she developed thrombotic microangiopathy by the evidence being the elevation in LDH, the recurrent drop in hemoglobin, the thrombocytopenia, and the development of these new effusions and ascites. So atypical HUS would be my diagnosis for the renal dysfunction. Unlikely to have these, of course, this was documented later, but this is a secondary ICU infection. Renal vein thrombosis was ruled out on the ultrasound. So what is the pathophysiology of these different diseases? So in preeclampsia and HELP, it is due to anti-angiogenic intermediates. So this is anti-endoglin. And they attack via VEGF and cause, in the setting of endothelial dysfunction caused by the placenta and the immunological reaction to the child. So this is what precipitates preeclampsia and HELP. So this is placenta-derived mediators. In TTP, it is a deficiency of ADAMTS13, which is the cleavage protease for von Willebrand factor. So von Willebrand factor multimers formed, endothelium dysfunction, it becomes sticky, and this causes microthrombosis. So this is TTP. And in atypical HUS, this is complement mediated. If only we had complement levels, maybe we could have been able to distinguish between two. But I would say the patient fits within this. And then how does this finally manifest? There are schistocytes, like we saw, hemolytic anemia. And with endothelium dysfunction, we have clot formation. And this leads to thrombotic microangiopathy, a systemic disorder. And this is what is likely to be seen on the autopsy. So that's what it looks like, TMA. We have hemolytic anemia, thrombocytopenia, secondary organ damage, which this patient had. Why did she develop respiratory failure? Well, I think it is mainly TRALI. This is an underdiagnosed issue in, delivery units or even in our ICUs. We transfuse too much. There could be postpartum pulmonary edema. She definitely had a pneumonia later on in the ICU. This was nosocomial. She was on a ventilator for a long time. Major pulmonary embolism has been ruled out on echo, which was done precisely for this, for ruling out. But that will only be detecting RV failure and cor pulmonale, and only if there's major RA-RV dilatation. So unlikely, but small vessel microemboli could be found because this is a patient with TMA. And most important message which I'm going to give to the students today, that we are labeling these as a separate disorder, but this is actually a spectrum disease. So patient has a genetic predisposition. There is an immune dysfunction that occurs because of this mediator, which is the placenta. It presents a parasite to the mother, tells her not to attack it, but at the same time, a rogue placenta may release some mediators which the mother cannot deal with. So that's what AFLP is. And as it's a twin pregnancy, there are two placentae, double the mediators. So when the patient goes from the second to the third trimester, the level of immunosuppression which is induced suppresses, it becomes inflammatory. So there's a switch in phenotype, which is why autoimmune disorders actually precipitate in the third trimester or postpartum, because the immune function of the mother switches from a immune suppressed to an immune inflammatory phenotype to expel the fetus. So pregnancy immunology is interesting to us because we are transplant hepatologists and we are interested in looking at how the body deals with an extraneous organism, which is a liver or it is a child. So environmental and immunological factors, if there is a deficiency in the ADAMTS13 complement, so all of these factors can precipitate a combination of these diseases. And of course, if the patient also had genetic mutations for ICP, she may also have had ICP because that's possibly was there in this patient. So my revised diagnosis would be AFLP, which is with pre-eclampsia, post-vaginal delivery with both losses of the children, even though this was an early pregnancy. There was a live fetus at presentation. Atonic PPH, coagulation failure, which was ALF related and also sepsis related. She had multi-site puerperal sepsis with SPP, nosocomial pneumonia, and also in the RPOCs. She had hemolytic anemia, which I think is TMA related. The AKI is pre-eclampsia related. Post-pregnancy, she developed TMA, and that's what we'll see. And then later on, there'll be septic ATN because 3 days she was on inotropes. The cause of death is refractory septic shock. So I think what we could have done differently would possibly be if we knew which type it was. So atypical HUS, complement deficiency, if we had diagnosed this patient, we could have offered eculizumab, of course, 2016. Plasma exchange is something we routinely do, by the way. Now, whenever we take patients with AFLP from the CLR, we have lowered our threshold for plasma exchange, and it works wonderfully. In a resource-poor country like India, transplants cannot be offered to all. So this gives some time to the mother to remove the toxic metabolites and allow the liver to spontaneously regenerate. Thank you.
Thank you, Dr. Madhumita. Now you can come and join me here. In fact, it's so interesting. Just wait. All right. The right is of the treating unit. That's the OB/GYN. So, Dr. Vanitha Suri, yes.
Good morning. Madhurima has discussed very well. In fact, I had discussed with her because AFLP is the diagnosis, but only histopathology will confirm it. Till now, there is no good biomarker or clinical parameter which can differentiate between AFLP, hepatitis, and pre-eclampsia induced liver damage. So therefore, we depend upon pathology. And as I always say, pregnancy is a systemic disease. Many of you may not agree with me. It affects you from head to toe. So whether what gets affected first and how severe it is, it depends upon patient's luck or immunity or that. Thank you.
Well, in fact, it's the most, I would say, debatable and controversial issue whether pregnancy is the disease. Yes, Dr. Inderpal, now you wanted to say something. Yeah, just a moment.
Well, I don't think there is enough evidence to label it as hemolysis. The retic count is 1.7, and if you see the retic count production index, it would be even less. So clinically, we cannot make hemolysis as a possibility here. Another thing is we do not have any cystiocytes in the periphery, and it would not be wise to call it as HUS.
Yes, Dr. Puja.
Definitely it is acute liver failure and maybe AFLP when she presented. But a very characteristic point in her history is that she had pruritus for 2 months. Pruritus means cholestasis. So cholestasis after 2 months goes into fatty change. I am not very sure. Something like primary biliary cirrhosis, autoimmune should be considered. Primary biliary cirrhosis presenting for the first time during pregnancy. And then finally, when she has the Swansea criteria, we can label everything as AFLP.
Yes, Dr. Ajay.
I think there is a school of thought which believes that AFLP, pre-eclampsia, and HELP could be, part and parcel of a same spectrum of liver diseases. So all these can coexist, and I personally feel that there is an overlap in this patient. But finally, I think the disease which, AFLP is much less commoner than pre-eclampsia and the HELP. But then it is more, fatal and fulminant. So pre-eclampsia and the HELP may not behave the way she has behaved. So I'll put more money on AFLP as the first diagnosis, number one. But I also feel that ultimately it got complicated with infection, sepsis. So in the autopsy, I expect not only the changes of ALP with microvascular steatosis, focal necrosis, but also maybe some changes of septicemic hepatitis, which may be there.
Ashish Bala. I'll request the residents to please come forward and take seats, lots of them.
Couple of things. 21 years old female, 34 weeks pregnancy, twins, is G2P0. What happened in the first pregnancy, we don't know. Maybe whatever was happening now had some, basis. There was something wrong with her earlier. She had probably 3 phases of illness. Number 1 was she had pre-eclampsia. She went on to develop AFLP. She came to us well within time. The fresh stillborn is 1.9 kg. She came and she gave us 48 hours. And she wasted 10 days outside. So maybe, I don't know, we waited for her to go into spontaneous labor and everything. The second phase came when she had a tonic PPH. We gave her FFP, we gave her blood, we caused TRALI, we possibly caused DIC. I would not consider TTP here. She has significant coagulopathy. We were responsible for giving her too many blood products, and that probably deranged everything. Then the third phase is sepsis and septicemic process.
Yes, Vivek.
I think my point has already been made by Dr. Bhalla. So if we were to see this patient after she developed, I would say florid renal involvement, and in the setting of multiple cultures being positive and with deranged coagulogram, I think the first possibility would be, I would say, sepsis with DIC. And in such a situation, if the sepsis improves, but the prevalent manifestations of so-called thrombotic microangiopathy do not improve, it is in this situation that we strongly suspect that sepsis along with pregnancy probably has acted as a trigger for atypical HOS-like state, and then we need to institute something for that. But having said that, there is no way I can distinguish at present that both these things are not present in this patient. So these things might be present, but as of now I think the first possibility from our side would be possibly sepsis DIC.
Yes, sir. In fact, it's practically impossible to differentiate clinically whether the coagulation abnormalities is because of sepsis, is because of preeclampsia, or is it because of liver failure. I believe the TEG is the only way, to look at specific factors. I believe it's 7 or 8.
I completely agree, sir.
Yeah. Yes.
So I distinctly remember this patient because she was admitted when I was an SR. Actually, I was a first-year resident that time, and she was unique because she had AFLP, she delivered, and still she worsened. And I think a strong possibility of the TMA syndromes was kept, but we did not have hard evidence of hemolysis in the sense that the schistocytes were normal. So apart from the LDH being very high, which could be a part and parcel of liver failure, we did not have an evidence of TMA. So I personally think that sepsis really was what took away the patient. And in the end, there was definite TIC, which would again have microvascular thrombosis, so the differentiation would become difficult. But what I'm really interested in is that the patient had ascites and pleural effusion, with the ascites being high SAG, that developed maybe 3-4 days after delivery. So in the setting of AFLP, ascites is a part of the diagnostic criteria of AFLP. That wasn't present pre-delivery. It came post-delivery, it was high SAG. And was there anything of surgical peritonitis there?
Yes, please. And please identify yourself too.
Good morning, I'm Dr. Praval, pediatric SR, allergy immunology. Another possibility to consider is, could this all be because of catastrophic EPLA? Because there is history of early abortion. She is young female. Platelets are also on the lower side.
All right, yes.
So there's a query between HELP, TMA and AFLP. I would like to inform the House that under the Allergy Immunology Unit, Professor Amit Rawat is doing AH50 and CH50. So we would have known what is the functional, we would have known whether the complement was activated. We also have intermittently factor H, factor I, anti-factor H is also available. So it would have helped maybe to differentiate.
I doubt very much, essentially because please remember that infections do, stimulate complement levels. They are all indirect evidence. So, in fact, the main issue is the overlap between acute fatty liver, HELP, and preeclampsia. And to say whether they are a spectrum, there is some overlap because I believe the pathogenesis is different for AFLP as well as for preeclampsia, because in one we have a beta fatty acid oxidation defect, and on the other side we have the placental issue. but there is overlap, and in India always the infection, supervenes. So it's a single insult, 2 insults, 3 or 4 is the real point. Yes, you want to add something? Or?
So very quickly, hemolysis versus none. Well, there's a split in the direct and indirect components of the bilirubin, and even though the patient was delivered, there's this gap. LDH is very high, and even though only 1 peripheral or 2 peripheral smears were sent, maybe it is not possible to distinguish always. So I think there is some evidence for hemolysis in this patient. She required recurrent blood transfusion. Chronic liver disease is unlikely. Liver was normal in contours. Portal vein was normal. She conceived twice by the age of 21. So I assume that an autoimmune panel and IgG was completely normal. So unlikely to have chronic liver disease. I agree with Duseja sir, AFLP is the way she should have been treated. Completely agree with Professor Bhalla, because we are overusing blood products in this institute, and we need to look at the sepsis induced by it and trali induced by it, and whether how much of it would be actually required. And as sir said, a TEG or a ROTEM, which we now have these devices, might help distinguish better. As per Dr. Vivek's comment, I completely agree. Sepsis and DIC was supervened later, but I think there was a phase where hemolysis was also there, and we know that it is associated with pre-eclampsia. And APLA, well, the workup was not done. I agree, it should be done in such cases.
Yes, with this now we come to the end of clinical discussion. Now we have Dr. Venkatesh to show us the pathology protocol. Venkatesh.
Good morning, everyone. I am Dr. Venkatesh, DM Senior Resident from Histopathology. I will be discussing the autopsy findings of this case. Complete autopsy was performed in this 21 years female with a clinical diagnosis of acute liver failure and sepsis. Prosectors at the time of autopsy noted the patient to be moderately built. The peritoneal cavity had either 100 ml of star colored fluid. However, pericardial and pleural cavities were within normal limits. I will begin my presentation with the examination of uterus and placenta. The uterus with bilateral ovaries and cervix weigh 750 and it appears enlarged. On cutting open, the endometrium appears dilated and it is covered with brownish friable material. Representative sections were taken from endomyometrium. The endometrium appears completely necrotic. However, there are no features of endometritis, bacterial organisms, and neutrophilic collection. The myometrium show many dilated and congested blood vessels. On examining placenta, placenta showed third trimester villi with an fairly circumscribed and an unencapsulated lesion, which on further magnification appears cellular and composed of many varyingly sized capillary-sized blood vessels. On further magnification, these capillary channels are lined by endothelial cells, which does not show any significant atypia, mitotic activity, and necrosis. Summarizing my findings, uterus shows postpartum changes and placenta shows chorangioma. Now coming into our organ of interest. This is the organ complex comprising a liver, C-loop of duodenum, pancreas, and spleen. Liver weighs 1150 grams and spleen weighs 150 grams. Cut surface of the liver is yellowish, greasy, firm to feel. However, there are no nodules noted both on the cut surface and on the capsular aspect. There is no significant capsular wrinkling. Representative sections were taken from the liver. This is the scanner view of the sections taken from the liver, which shows maintained lobular architecture. On further magnification, the hepatocytes show distinct tinctorial quality. Means the hepatocytes have distinct area of paleness and distinct area of darkness or eosinophilic nature associated to it. The dark or eosinophilic hepatocytes are adjacent to the portal tracts, corresponding to the zone 1 areas. However, these paler or clearer appearing areas are centrizonal in nature. Mason trichrome highlights the zonal nature in which these paler areas are appreciated around the centrizonal area. However, these eosinophilic or darker areas are appreciated in the periportal area. The periportal area does not show any fibrin deposition areas of hemorrhage. In addition, there is no significant portal-based inflammation, fibrosis, and there is no significant lobular inflammation. As we go into the higher power, the hepatocytes in the centrizonal area appears swollen, and they have multiple uniform-sized vacuoles with centrally placed nuclei. Further moving on to the high power, these hepatocytes in addition show prominent hepatobiliary plugins. On diligence searching in Mason trichromatine, an occasional megamitochondria was also identified. Oil red stain was performed and it showed positivity within these hepatocytes, indicating microvesicular steatosis. Reticulin stain show reticulin condensation. However, on Mason trichrome, we could able to appreciate this thin bluish strands connecting the portal region and occasional portocentral region, indicating it to be a confluent and bridging hepatic necrosis, not fibrosis. Spleen shows red pulp congestion. Pancreas does not show any significant microscopic findings. Summarizing my findings in the liver, we have centrizonal microvesicular steatosis with the cholestasis and confluent and bridging hepatic necrosis. These morphological features are suggestive of acute fatty liver of pregnancy. Now moving on to our next organ of interest. This is the organ complex comprising bilateral lungs and trachea. Bilateral lungs together weigh 1020 grams. The trachea show focal ulceration. The cut surface of the lung is diffusely consolidated. On further magnification, we could able to appreciate these multiple nodular hemorrhagic areas present on both the lungs. No pulmonary thrombus identified. Representative sections were taken from these hemorrhagic nodules, which shows large areas of this bland necrosis. At the periphery of the infarct, we could able to appreciate this medium-sized artery with fresh fibrin thrombi within them. As we move on, the higher magnification of the bland necrotic area shows numerous fungal organisms, which are slender hyphal organisms. PA stain was performed, which better appreciates the morphology of the fungus. These fungal organisms are slender, septate with acute angled branching. GMS stains also highlights the fungal organisms with similar morphology. These fungal organisms are seen invading the wall of the blood vessels, indicating angioinvasion. Sections taken from adjacent lung parenchyma shows large areas of necrotic inflammation, which also on higher power shows these numerous fungal organisms of similar morphology. The sample has also been given to microbiology department. Pan-fungal PCR was performed. Aspergillus species was confirmed, and we thank Dr. Shivaprakash sir and Dr. Harshimran ma'am for performing pan-fungal PCR for us. The adjacent areas of the lung show pulmonary edema and deposition of the hyaline material within the alveoli, indicating diffuse alveolar damage. So summarizing my lung finding, we have invasive pulmonary aspergillosis, and we have pulmonary edema, and we have diffuse alveolar damage in exudative phase. Moving on to the brain appears swollen, edematous, and weighs 1444 grams. On coronal slicing, numerous these irregular hemorrhagic nodular hemorrhagic areas with central areas of softening were noted. In this coronal slice, we could able to appreciate this lesion in the anterior part of the left temporal region. These are the multiple panel of gross images showing these hemorrhagic areas in the different parts of the brain, which includes right anterior frontal region and amygdala. Representative sections were taken from these hemorrhagic areas. This is a scanner power view, show brain parenchyma with this ill-defined nodular lesion, which on further magnification appears to have a necroinflammatory reaction. On further high power, this area contained predominantly areas of necrosis, neutrophilic debris, and fibrin thrombi. PAS stain was performed, and they show this fungal hyphal organism with septations confirming the morphology of Asper. GMS stain also highlights the similar fungal organisms. The adjacent brains show reactive gliosis, and the meninges overlying this necroinflammatory reaction show focal meningitis. And this is an organ complex comprising bilateral kidneys, part of abdominal aorta, IBC, bilateral ureter, and urinary bladder. The capsule of the kidney is shiny and it is strippable. There is a distinct corticomedullary distinction, and there is no pelvic axial dilatation noted. Representative sections were taken from renal cortex, and from the low power we could able to appreciate the glomeruli showing distinct lobular accentuation. On higher power, there is mesangial matrix expansion with the hypercellularity, and we also have a segmental endocapillary proliferation, however, with basement membrane thickening. However, there are no fresh fibrin thrombi identified. PAS highlights the basement membrane thickening better. DAF, direct immunofluorescence, were performed on the pronase treated sections, and it is negative for IgG, IgA, and C3. Tubules, in addition, show this brown colored coarse cast. On Fauchett stain, this cast demonstrates emerald green positivity indicating bile cast nephropathy. So we have in kidneys, we have mesangial proliferation with the focal endocapillary hypercellularity and DAF negativity, suggesting thrombotic microangiopathy and bile cast nephropathy with a severe acute tubular injury in the kidneys. The arterioles in the kidney show mild myxoid deposition, however, no fresh fibrin thrombi noted. Heart weighs 240 grams, and there is loss of epicardial fat. The heart was dissected through modified inflow-outflow method, and all the chambers does not show any vegetations, thrombus. The ventricle wall thickening was appropriate for age. There was focal patchy subendocardial hemorrhage. Representative section shows intramyocardial hemorrhage. Esophagus with the stomach grossly appears unremarkable. The serosal aspect of the small intestine show focal patchy areas of hemorrhage. However, representative sections taken from gastroesophageal junction, small intestine, and colon are unremarkable. Sections taken from adrenal, skeletal muscles, skin are unremarkable. The bone marrow appear cellular for the age with the adequate tri-lineage hematopoiesis. So my final autopsy diagnosis in this 21 years female patient is postpartum changes in uterus with the placental cholangioma, acute fatty liver of pregnancy, invasive pulmonary aspergillosis with the dissemination into the brain, diffuse alveolar damage in the lungs in exudative phase, membranoproliferative pattern of glomerular injury with the DAF being negative, suggestive of thrombotic microangiopathy and bile cast nephropathy. Thank you.
Please come and join me here. Now, both the clinical and the pathological protocol are open for discussion. Naturally, there will be many points. The first point is, Venkatesh, you can answer straight. Did we have any evidence of pre-eclampsia, that is swelling of the endothelial cells, some lucent subendothelial space, and so on?
Liver in pre-eclampsia, so portal region, fibrin deposition, hemorrhage, and marked hepatocytic necrosis. We have taken adequate number of sections from the liver, and we didn't see any evidence of pre-eclampsia changes in liver in this case.
All right. Similarly, yes, Dr. Ajay, can you comment on the extent of hepatic necrosis? You know, just going through, spotty necrosis is really seen in liver, but such extensive necrosis, that's the zonal necrosis, bridging necrosis.
Yeah, I think that was the question I was about to ask. Thank you, Dr. Venkatesh. I think beautifully showing us the morphology of AFLP microvascular steatosis, predominantly zone 3. So zonal distribution is also very, very important. And the portal tracts were kind of free of any inflammation. I think that's very important. But what I am asking you is about, the bridging. Typically, they have spotty necrosis or, here and there necrosis. The bridging or a confluent necrosis in this lady is probably that she went into acute liver failure, and ALP is a spectrum. If you pick them at early stage, you may just find some spotty necrosis. But at this stage of ALF, I think you probably would have, confluent necrosis. So that's explainable. My question to you is about the cholestasis which you have shown. We discussed before autopsy about the possibility of ICP, to which I don't think was a strong possibility, because ICP, this is not the usual clinical course.
I would advise you to use the full form.
The intrahepatic cholestasis of pregnancy. Unlikely, because, but then the cholestasis, I thought, could it be because of, again, sepsis? Yeah, and you didn't show any changes of infection there in the liver. Yeah.
Sir, even acute fatty liver of pregnancy can show per se cholestasis. This patient had a clinical evidence of sepsis in form of new blood culture showing bacterial organisms. So, differentiating this cholestasis is due to sepsis or whether it is associated with the ALP is difficult at this point, I feel.
I'll request the gynecologist to please comment, because this person, we have to have clinical pathological correlation, because this person had pruritus.
That is the question. This patient had cholestasis since 24 weeks of pregnancy, and cholestasis of pregnancy does not worsen like this. Why is she having cholestasis at 24 and then she has acute liver failure at 32 weeks with twin pregnancy with Swansea AFLP? So I wanted to know why there is cholestasis at 24 weeks of pregnancy.
Ma'am, intrahepatic cholestasis.
She didn't have cholestasis, she had pruritus. There was no evidence of cholestasis.
Yes, Dr. Usha.
Yeah, I think we can't get away from the fact that at 24 weeks she had pruritus, she had elevated bilirubin, she came in with a very high alkaline phosphatase. So she was given UDCA. We don't have documented bile acids, but we cannot get away from the diagnosis of intrahepatic cholestasis. In twin pregnancy, it can happen earlier than what you expect normally in the third trimester of pregnancy. And the other thing, learning point for the residents, is that because of sudden collapse of the reticulant framework, you can have ascites, which is high SARC.
So
Yes,
we can't run away from the diagnosis of ICP, but we don't have an LFT like Dr. Suri pointed out. She just had history of pruritus, so gestational pruritus is very common. However, we assume, even if we assume that there was a genetic predisposition to ICP, it does not prevent her from having a superadded AFLP. That's what we want to communicate, that these are not isolated disorders, they can coexist.
Right. Good morning. So, as already mentioned, that the cholestasis could be multifactorial. So, we cannot get away from sepsis definitely. So, sepsis could be definitely, it causes cholestasis. AFLP per se can show cholestasis. And ICP, it shows basically bland cholestasis. Sometimes we can see some degree of portal fibrosis, but at autopsy, if we find bland cholestasis, in this setting we are having a lot of microvesicular steatosis and a lot of septicemic changes. So we cannot say whether this is because of there was ICP or not without resorting to maybe IHC or sequencing. So at this point of time, this could be multifactorial.
Yes, Dr. K. So I'm actually getting confused now. How many diseases this person has? 4, 5, 6?
Yeah, I think we had seen in this wall intrahepatic cholestasis of pregnancy, I think in the student CPCs and all. And I think in that particular situation, the liver grossly also would be totally green. There would be much more cholestasis. And these, I don't think there was significant cholestasis because grossly also the liver was rather pale. So I think that can be excluded.
Yes, Dr. Palla. And would you comment on the fungal infections which you have seen rampant in patients of liver disease? Does the liver disease actually attract fungi?
I don't specialize in fungal infections, but my comment is one, that that this patient had multiple infections, but didn't have puerperal sepsis. We didn't find any uterine or placental evidence of infection. So my point is, growing an organism which is a part of normal flora of either the reproductive or the GI tract from a non-naturally expelled placenta doesn't necessarily mean an infection. Because in the second half of pregnancy, the vaginal flora gradually transforms into a mixture of reproductive and GI tract, nature's way to to prime the fetus transplacentarily through the end products of the normal flora. Therefore, growing any organism doesn't necessarily mean that there is an infection.
Yes, now we have the mycologist to come. Yes, please.
Sir, actually, liver disease is an emerging risk factor for invasive fungal infections, especially in the critically ill patients. In one of the multicentric study where Chakrabarti sir was the coordinator, we found 7% of the cases in around 400 cases all over the India where ICU patients were enrolled. 7% had liver disease as risk factor, and out of these 4.3 were chronic liver disease. There were few acute liver disease patients.
Yes, Nipur. In fact, I was always thinking, there are two organs. One is the liver, another is the pancreas. Pancreatitis and liver disease.
So, regarding acute liver failure, we recently analyzed around 140 patients. Around 15% had fungal infections. Around 5% were proven infections. None of them survived. So, fungal infections in acute liver failure is so detrimental. Empirical treatment or even prophylactic treatments are now being tried. We don't have yet any RCT on that. Regarding chronic liver disease and ACLF patients, again, it is a recent systematic review we have conducted around 38 studies, 14.8% prevalence in India, and amongst them the culture positive being again 6%. So the mortality is higher than general medical population patients, around 70-75% compared to 40 to 50% in general medical population, including ICU population.
Yes, Dr. Bish. But let me just warn you that fungal infection is of three types: probable, presumptive, and definitive. So it all depends on in which category these fungal infections belong.
Well, I wanted to respond to your this thing that is liver disease attracting fungus. No, I don't think so. I mean, this is very well known. Right in 84-5, when I used to show fungi in CPCs. 89 we wanted to publish also a large series. In fact, that time also we knew that renal diseases, dialysis, and the liver diseases were a predisposing factor. And I'm talking about 30 years back. Any organ failure. So I don't think liver. We have shown fungus in each and every case in this hall. So each and every case is not liver disease. So liver disease per se is not. In fact, what I can say is that where our hospital, whether it's RICU or it's full of fungi, autopsy we have shown you name any disease we have shown you, whether it's a brain, liver, kidney, lymphoma, fungus is there. So I don't think we can now say that the liver is attracting fungus. There are fungus everywhere. Any patient dying here, I think, and Sanjay, you know very well.
Yeah.
We have
I knew that your microscope was actually fixed with fungus. In fact, it was a rule 20 years ago that if Bishan is presenting, take it my word, he has to show fungus. Yes, please.
My comment is regarding two things. One is pre-eclampsia, second is infection. Venkatesh, what about the membrane rolls? Were they reported the membranes submitted for histopathology along with the placenta? Did they show any evidence of chorioamnionitis? Was there any funicitis, anything like that?
No, ma'am. Membranes does not show any evidence of chorioamnionitis and funicitis. So,
very unlikely that there has been puerperal sepsis. Second is, although you mentioned the liver changes of pre-eclampsia, there are also changes in the uteroplacental vessels, particularly at the site of placental implantation. Sometimes we get to assess the vessels along with the decidua which comes with the placenta itself. But one has to look very carefully, and sometimes the changes can be very subtle, or if it is florid, you can have changes like of acute acidosis as well. So maybe we can go back and look at it. Maybe we have not looked at it so thoroughly, but maybe. And the last comment was this chorangioma that Venkatesh showed was just incidental. I mean, it had no bearing on the rest of the disease. Thank you.
Yes, Vanita Jain.
I just wanted to say that we have about 70 to 80 maternal deaths per year, and of these, 10 to 15% are due to acute liver failure. So we are very frequently seeing these kind of patients in the critically ill patients, and it is very common to have a differential of AFLP and a severe preeclampsia, which is not sorted out till the end, mainly because the symptoms are overlapping and also they coexist. So in this case as well, we will not go away from the diagnosis of preeclampsia simply because not many histopathological changes are shown. It is preeclampsia as well as AFLP. And practically speaking, differentiation may not be very relevant because both of them have the same treatment, that is to terminate pregnancy and to give a maternal support. What we need to differentiate it from is the other etiologies of liver failure, like the viral etiology, where we do not intervene and we do not terminate pregnancy. So this is a very common scenario where query AFLP, query preeclampsia, we are facing it day in and day out, and the management remains the same. So finally, in our maternal death analysis also, they remain as query AFLP and query severe preeclampsia. And this patient also I think had both of them. Thank you.
Dr. Jayanta.
I just wanted to add on to what Professor Jain said. I completely agree, because AFLP, one needs to deliver the source of the fatty oxidation defect, the products. So one delivers the child to protect the mother. And in preeclampsia and eclampsia, we need to deliver the child to protect, protect the child as well, and also the life of the mother. So it's important to timely deliver these cases. Only in viral hepatitis with ALF can we wait for spontaneous delivery to occur. My question is that if this patient definitely had preeclampsia, she had high blood pressure record, she was getting labetalol, there's no doubt about it. Maybe it takes time for those vascular changes to be visible so that it is pointed out on histopathology. So we cannot deny the presence of both preeclampsia and AFLP in this case, which has been beautifully shown. The latter has been shown on histology. Another point is this patient has angioinvasive aspergillus, and in the brain and also in the lung. So how long, because we gave her antifungals, I think by day 3 or day 4 of LIC admission, which is a standard protocol, ALF, if we're seeing sepsis, we start. How long do you think, sir, Vidya she would have had this for it to have these kind of hemorrhagic changes in the brain?
Yes, Ridhambra. So this is CPC, where the clinical parameters are correlated with the pathology parameters. Now, 80% of times they will match. You'll have a clinical parameters, you'll have the pathology corresponding features. But 20% of times, either the clinical features would be there, pathology features will be there, for which you will not have explanation. And that's the reason of holding all these meetings. Yeah. So would you please try to say that actually what is the gold standard of preeclampsia? Because preeclampsia by definition is a clinical diagnosis. Yeah. Nowhere actually in the diagnosis of preeclampsia histology is mentioned. So what will you say about it?
So good morning everybody. That's what I thought I'll just say, whether the TMA which we have seen, this patient has bile cast nephropathy, which can explain your AKI, but this patient had proteinuria much before the delivery, or if we assume it to be sepsis induced. And morphologically what we are seeing is a chronic TMA with a membrane reduplication. That means it is of some duration. So even it has not occurred at the time of delivery, it was present beforehand. So possibly that might be a morphological expression of preeclampsia which we are talking about. In liver, we would have seen those periportal fibrin and the sinusitis and all, but those are acute changes. I don't know how they would look when they are chronic, because the kidney pass looks chronic, but whether those changes which we expect to see in liver and periportal areas, what would be the chronic counterpart of that I'm not sure, because that's not my area, and we have not seen such cases at a chronic stage, because obviously if the patient dies, we see the terminal thing, we don't see what would have happened if that patient survived. But as far as kidney concerned, it appears that chronic TMA was there much before, and that could be a morphological expression of pre-eclampsia, which we are kind of expecting or we are considering. And I really like the fact Dr. Madhu Mehta has mentioned, we try to compartmentalize the diseases. This one has only AFLP, this one has only AQS or something like this. In body, I think it's multifactorial. All these LCAT defects will affect coagulation, will affect RBCs, and will affect liver and kidney, so as to say. And one more point was, since TMA is limited to kidney, and we have not seen DIC in any other organs, and we did not have arterial and venous thrombi, so applies out, DIC doesn't seem to be present morphologically. If clinically, if by labs it's there, it is there, but TMA is a morphological expression, not of DIC. It's a separate entity where angiopathy is there, the changes in vessels are there, which is not what we see in DIC, where we see only luminal thrombi.
Yes, Dr. Bishan, any last minute? And sir, would you like to make Dr. Chapter?
To answer Madhumita's question for how long these lesions will do, it's very difficult to, at autopsy, particularly when there is acute necrotizing aspergillosis, the lesion could be of 2 days duration. There are no actually parameters to say that these are 2 days or 5 days or 7 days. Once the infection is has gone to the brain, very few chances. But let me tell you, this patient has not died of aspergillus of brain. You know, there were 4 or 5 lesions there. It's the cause of death in this patient is pathology of the lung.
Dr. Chala, would you like to add? And that'll be the last comment for the meeting.
Very interesting case indeed. AFLP and viral hepatitis induced ALF was always the confusing point whenever such type of patients used to come. And it was usually acute liver failure because of viral hepatitis, which was more common, except if on ultrasound we used to see a white liver. Somehow, for some reason, in South India, AFLP is more common than acute viral hepatitis as a cause of liver failure. And they used to do in Vellore LCHAD deficiencies, which I think would help to some extent in picking up these cases. I don't know what is the spectrum now of acute liver failure in pregnancy. I'm told that HEV-related ALF has gone down significantly. I don't know what is the picture in PGI. And I'm sure with that having gone down, AFLP must be picking up.
Yes,
more
Kevin,
often.
you wanted to say something. Yes, she's been raising.
I have not seen the case, but Venkat, I will say that the case, your photographs were not very good. It was really blue, very bright. And there was a lot of changes even in the periportal hepatocytes. They have lost the cord pattern of arrangement. There were a lot of regenerating hepatocytes. I think that your case needs to be relooked again.
Thank you very much. And